Good afternoon, everyone. Myself, Dr. Wing Commander Tushar Zanzar, welcome you all on behalf of ICT Academy today for this live webinar on the topic New Technologies for the Better Success in Vitro Fertilization in today's era. For this talk, it has been now more than 14 years when in vitro fertilization a has come into existence to our reproductive medicine practice, and it has changed the world and fulfilled a dream of a lot of parents who were suffering from a infertility. So as there is a growing aspects of infertility everywhere in the world in form of awareness about patients, availability of the so many doctors, and availability of clinical support, as well as accessibility of the patients towards the this infertility setup. I would like to invite today our esteemed guest speaker, uh, Professor Colonel Dr. Pankaj Talwar sir, Vishishta Seva Medal. In short, I will introduce Sir in shortly. Sir, I extend my warm welcome for today's webinar.
Thank you.
Sir is the CEO at iHoma Infertility Clinics and IC Training Academy at Gurgaon as well as Delhi. Sir has been a dean at Sridhar University, Pilani. Sir has been also awarded a doctorate in a clinical embryology. Sir has been a president Indian Fertility Society for the session of 2024 to 2026. Sir has published more than 100 articles and edited more than 9 books in ART. Sir has several research papers. Also, he was director and the head of the department for the ART Center at Army Hospital Research and Referral, New Delhi, as well as Birla Fertility Center. So, sir, with this vast experience of sir has taught about more than 1,700 students globally and has a wide experience of setting more than 30 ART labs all over the world. So, without wasting a time, I would like to invite Sir. Sir, once again, warm welcome to you, sir.
Thank you,
And
Tushar.
over to
Thank you
you.
very much. Thank you so much, Tushar, and it's always good meeting you again. And for everyone present there, I think we do it every 15 days now on demand of all of you, and we try to cover various topics pertaining to infertility. Our aim is to keep topics very simple, which you want to learn about, and we want to cover things in a very simplistic way. And till now, we have covered wide number of topics like PCOD, endometriosis. We spoke about OPU needles, IUIs, and today I thought we'll go to a new topic. You all want to know what all are the technologies available to us by which we can improve our chance of getting the pregnancy in infertility. So we'll be picking up around 9, 10 topics today and talk about them. What are these technologies which can help us to have a child in a more positive way? What all are the methods which we can add to our treatment? Some of them are add-ons or empirical therapies, by which we mean that they may not have a definite utilization in the whole of IVF process, but we do use them because they won't cause any harm and they may help to get the baby. So we'll talk about the various technologies for the female, male, something about immunotherapies, so that all of you are watching our video can go home with some take-home message: what is good, what is bad, and I again welcome all of you. We have on board with us today Dr. Tushar. He's from Nagpur. He's my colleague from AFOS, and I'm very sure that we'll make it a very interactive session for next half an hour to 45 minutes. My greetings to all the people who have joined today. Many of you will be our patients, or many of you will be the doctors who are training with us. I think it will be a very good opportunity to interact with each other and learn more. So, with this, I hand back over to you, Tushar, and you can start with the questions.
Sir, thank you, sir. Sir, coming to the marketing era of the IVF, first of all, I would like to do everybody advertisement. Visit our center and take a baby out. Uh, as we all are witnessing in the world this today. So everybody promises our success rate is 90%, 100% for IVF. So what is your opinion about with these modern technologies, sir? You are the boss in the field. So what would like to say to about up to our patients, sir, about
I
this?
think I quite, मैं Tushar, I am very orthodoxic. What we learned in the army, working, heading multiple units, that we have to keep our life simple and the life of our patients simple. Uh, Patients nowadays are anxious, yes. Many of them they come to us late and they are in a hurry. Some come very early and even they are in a hurry. Today, everyone wants to have something like instant food, like Maggi noodles. Very quickly, they want an answer. We are all
Sir,
becoming impatient. But I think so. It's very important that we should not do anything which is not indicated and do the correct things for the people. And that doesn't entail adapting to the newer technologies. I mean, some of them are okay, some of them are controversial, some of them are plain empirical. So you have to pick them up depending upon after talking to the patient, and they should have an indication. Like a lot of people nowadays, the moment they come to us, they feel that PGS is a part of IVF treatment. They feel
sir,
that PGS तो करना ही है, biopsy तो करना ही है. I wonder from who's teaching them, who's grooming them. A girl may call me from some village in say Hisar. She'll call me बोलेगी मुझे IVF करना है, आपके पास लेजर है. I wonder a girl who's speaking in a native language doesn't seem to be very educated. Somebody from middle class family like us. उसका पहला सवाल रहेगा आपके पास हैचिंग होती है लेजर है आपके पास they are learning from doctors, they're learning from the social media, and somehow it is going into their mind that technologies will improve their outcome, which I don't agree at many points of time. So that we'll be covering today. The
sir,
IVF outcome has has slightly gone up, but all over the world, I think the take-home baby rate has not gone up till now. The pregnancy rate, if you look at it, is all around between 65 and 70%. But now it all depends upon what type of population we are handling. In case I say that my rate is 70%, that will be wrong. ये गलत गलत अतिशोक्ति होगी because it depends upon what is their background, what is their age, what is their cause of infertility. So depending upon these things, I say an overall pregnancy rate will be around 65%. The normal population over one year will be around between 60 and 65 years because we get large number of people who are over age of 39, 40, 42. I think their pregnancy rates are not all that high. So we stabilize at around 60%. If you look at the whole lot coming to us, younger people may touch 70, 75%. But a cross section over 1 year, getting everyone in, will be around 60 to 65%.
सर। सो हमने आज सर से ये सीखा है कि ये बहुत जरूरी है, एडवर्टाइजमेंट कोई कुछ भी करे, बट आईवीएफ का सक्सेस रेट इन बहुत अच्छे सेटअप में 60-65% के ऊपर नहीं हो सकता है। कोशिश भले ही की जा सकती है, बट हमें ये भी साथ में सोच के रहना पड़ेगा कि व्हाट विल बी द आउटकम टू व्हाट एक्सटेंट। सर एक नई चीज और हुई है सर, एज द मार्केट में बहुत मार्केट इन द सेंस दुनिया में अभी बहुत सेंटर्स खुले हैं, हर जगह ही खुले हैं, तो कॉस्ट ऑफ आईवीएफ इज गोइंग डाउन डे बाय डे, व्हाट पीपल आर सोइंग। सो माय सिंपल क्वेश्चन इज सर कि आजकल जो नए नए फॉर्मुलेशन आई है, नई दवाई आई है, फॉर एग्जाम्पल वी यूज द रिकम्बिनेंट प्रिपरेशन इंस्टेड ऑफ रेगुलर बेस। सो इसमें आपको क्या लगता है, आर दे यूजफुल? बिकॉज जैसे ही अपन न्यू टेक्नोलॉजी इंप्लीमेंट करने जा रहे, प्रोसेस का कॉस्ट भी उतना ही बढ़ेगा, ऑब्वियसली है। सो व्हाट इज योर मैसेज फॉर दिस थिंग सर, कि शॉल वी गो विथ रिकम्बिनेंट टेक्निक्स और वी गो थ्रू द रेगुलर प्रिपरेशंस?
I totally with you. I agree with whatever you're saying that, see, the rates of IVF are coming down, not because that IVF rates are coming down, but probably people now have become more, they market in a different way. What they say is that, okay, we'll do an IVF. Rate of IVF can be say X, and later on when the IVF starts, they keep adding some different money for ICSI, different money for freezing, different money for laser hatching. You keep adding small component, and finally you get a price. I think that in any average center, the cost of an IVF will touch between 1.6 and 1.8, which includes all the drugs. That should be one thing very, very clear. I feel that in 1.8, even sitting in daily, when you're working, around 1.8, 1.75, you should be able to do the case for a couple, even with the recombinant hormones, part recombinant, part HMG. So I think what is needed with all of us is that we should be having more clarity, and we should all work in a very clear way, clear conscious, give it to the patients in writing what it will entail, and whatever said and done, even for Pixie, in case we do for the male or we do some microfluidics, I think we should be able to wrap in around 1.90 for any couple, and then it should include everything till first embryo transfer, freezing, thawing. It should include that. Now, coming to recombinant versus HMG, in case you can get an HMG from a good company. See, now initially we were quite vehemently using something like we wanted to use a lot of FSH, but nowadays we have enough indications to say that even PCO patients they need some amount of HMG because they may be having defective LH receptors. So nowadays, for anyone who's more than 38 years of age, anyone who's elderly, previous IVF failures, even PCOD patients, I think we add HMG from the very beginning. So in case you get HMG from a good brand, HMG from a good brand in case we use that, that can be as good as FSH. Definitely, yes. FSH gives us the recombinant technique is filled by mass. It will give us a very reflective outcome, an auditable outcome because the packaging is superly done. But I don't feel that we should be moving towards pure FSH or pure HMG. We can use them with discretion. But in case a patient is not affording, definitely HMG is a very good choice. I do use HMG quite a lot for the people who can't afford. And as such, anyone who's got an age of more than 38 years of age, I prefer to use HMG only. So HMG is my very dear drug. But we do use HMG from a good brand. That's very, very important, where we are very sure of uh, the, the the concentration, how many units it is, and cold chain has to be maintained, and it works pretty well. So HMG is very good from my side.
Sir, with availability of the modern products for the IVF cycle, sir. The second part comes from the male fertility issues like sperm preparation techniques. Traditionally, we are using sedimentation, double density, single density, and simple sperm washing method. Nowadays, the availability of the new methods on the basis of principle of there are so many, sir, like glass wool filtration method, zeta potential, based on the principle of magnetism. So, are they good enough to give? Are they have been proven to be enough for a better result, sir?
I think male plays a very important role nowadays. Uh, are they either we are detecting more number of males who are having a problem, or their number is rising? I can't be very sure, but I think the male factor is getting trickier day by day. So till now we have been doing the standard methods of sperm separation where we do some washing, then we do some swim ups, we clean by centrifugation, we can use plain simple medias, or Tushar we also use density gradient media. So they give us very good outcome. But the only issue here comes is that sometimes uh, we get a sample which is a good sample, very good sample. Sample is not bad. So it can be very bad sample. Every samples are normally between say 14 to 14 or 15 to 16 to 20 million. I think we should always the sample preparation should be done as per the guidelines, as per the recommendation, whatever technique we use. But we should not use only one technique के मैं ऐसे ही सीमेंट सीमेंट सैंपल को बनाऊंगा. It's very important to do sperm testing around 1 to 2 months prior to the IVF cycle, number one, or an IUI cycle. Number two, we should know in case the sample is having any pus cells, we should have done their semen culture. Number two. Number three, morphology should have been done for that patient. And it's not always a count. So, Tushar, it's not the numbers which are important.
Quality,
Less number can be okay, but the morphology has to be good.
morphology, and the motility
Good
should be.
morphology, clean sample, motility, hyperactivation, these things have to be good. So for this, I personally feel that we are now gradually moving away from the standard methods of sperm preparation like double density, which entails centrifugation. हम जब भी सैंपल को स्पिन करते हैं, we tend to get some sort of we can create some sort of damage to the nuclear membrane or the plasma membrane. So I normally prefer my sample is very good. I prefer simple swim up. where I don't do any centrifugation.
Sir.
The sample is average. I think we're going for sperm separation
Fertility.
device. We don't have any, or we can use some microfluidics or any device with a polycarbonate chamber, which won't lead to spinning of the semen sample. So it's a very good method.
Yeah.
They're slightly expensive, but they take away your stress of centrifugation. They save your time. I think here I agree that we should be picking up a thing which saves our time. We may be spending bit amount of more money, more say rupees 1500 more, 2000 more, but we get very good quality sperms and very quickly we can get them. So sperm separation devices are very good. But more than that, Tushar, the problem comes when the sample has got poor motility, when the sperms are having astenospermia, when they're not moving properly, the number is variable, and they have bad morphology. We call it OAT, oligoastenotratospermia. Here I feel that I think a very good method is using microfluidics, number one. No spinning here. The sample is
Sir.
got oats, please don't spin the sample. Not recommended. I think we should do a plain simple swim up, get few sperms. But we don't need many for IVF, and then I go one step ahead here. That after we have done the sperm selection by microfluidics or sperm separation device or a plain simple swim up, even if we get few million sperms, we can now subject them to a thing called Pixie.
Fix.
Pixie is a very good technique where we can actually select the good type of sperms on basis on how well they bind with the hyaluronan coated slides. So it's called a petridix. It's called a physiological ICSI or petridix ICSI. It's called Pixie. This is what I do quite a lot. That way, I'm able to get good quality sperms because any sperm which has got which can bind with the hyaluronan will have better morphology, better DNA. That's the way I move on. They for this we have to spend some more money. We may have to spend rupees 15,000 more per case. But overall the outcome becomes very, very nice. So this is a good way. It's a very good question. I think now we should like in the female partner we say that we'll have to finally come to the point what type of protocol to be used, HMG or FSH, what dose, AMH, AFC. Same thing with a man. The man also deserves a lot of attention and love and care. So man is also our baby. Normally we only focus on the female partner. We never look at the man. So the man has to be seen in a very nice way, and then we have to select our technology depending upon his sperm count. So important two messages I want to give to you that all the people who have joined us today, आप सबको जानना है कि आपके जो स्पर्म्स हैं उनका मॉर्फोलॉजी कैसा है. Morphology kaisa hai, and secondly we have to morphology is the shape of the sperms, how the shape of the sperms inside and outside, and also how they move. The numbers are not very important. Numbers are important, but more important is how is their motility and how is their morphology, and depending upon that we'll pick up a particular technology.
Sir.
Thank you, Tushar, so much for this.
Sir, there is a question from the audience. Was there like a testicular sperm can be subjected to microfluidics for testicular sperm extraction?
Yes. So it's a very nice thing. She's saying that can we do so about testicular sperms? No, testicular sperms are very less in number. That's from Sumitra. Testicular sperms are very less in number
Yeah.
actually. That's the problem. The number is so less. In case we do PISA, when we take the sperms from epididymis, sperms
Yes.
number may be good, and we can use an small separation device which is meant for ICSI. There we may be able to utilize it. But for testicular sperms, where we get very few sperms in total, we get only 8, 10, 15 sperms. Microfluidics may not work here. Here be the best thing here will be. So Sumitra, a very nice question as always. You're always one step ahead. So here, what I say is that we should be using something called sperm mobile, which are the calcium ionophores or pentoxyphylline. We use these sort of things which will help in activating the cat spur channels. So when they get activated, sperm they start moving because the testicular sperms are not moving. You
Hmm.
don't need microfluidics here. The important is that the sperm should be motile, number one. When they're not moving, you have to find out whether they are dead or they're not. They are just tired or they are immature. So use some sort of ionophores, use some sort of pentoxyphylline, theophylline that will make the sperm move. So we can pick up the sperms which are moving now and subject them to Pixie, not ICSI, Pixie, and here you'll get a good outcome. This is what I want to tell you here. So testicular sperms, very few number of sperms, immotile sperms, microfluidics may not work for you, but epididymal sperms may help you. And then Usha Yadav madam says 5,000 per unit. I think he's talking about the any of the devices.
Sperm
So
methods
madam,
for.
yeah.
There
So
is
what
also
she's
question about lens hook, sir.
yeah, I'm coming to that only. They're all FDA approved devices. But what she is writing is that it is costing, probably she wrote in, when I said 15,000, she wrote about what's the cost price to an organization. So what
Yeah.
happens is that the kit will cost you around rupees 5 to 6,000 rupees. But when the whole procedure is completed, when somebody should do it, somebody has to prepare the semen sample, somebody has to mount it on the slide. The whole this whole dish preparation and finally giving a sample, there are charges, there are lab charges here. So like buying a device maybe some amount of money, 10 rupees, but there are lab charges, there are charges for the embryologist,
Processing will
and
take.
these are processing charges. Then finally we have to pay two people. I mean, that's the way it is. It's not only buying a thing, like buying a car may cost us 1 rupee. But car maintenance, car running, and car taking care of a car every day, that costs money. So somewhere it will touch around between 10 to 15,000 rupees for one procedure. That will include the costing of an embryologist, costing of the lab. It costs more. Is the device worth of it or not? I'll keep my opinion guarded about any brand. I don't talk about brands here, but you know that I love these devices. I love these devices, and I train around 40 people. I train minimum 40 people per month about the devices on average. I devise 40 people per month. I'm training on these devices. But here I say that I won't talk about a particular brand. Brand is your choice, but these devices are the future. मैं इतना बोलना चाहूंगा डॉक्टर उषा कि ये फ्यूचर इन्हीं डिवाइस के साथ में है. आने वाले समय के अंदर वी हैव टू बिकम इंडिपेंडेंट. We have to do things in which we don't need many people to work on it. So in case you learn how to prepare semen sample by this particular device, you'll cut down the price, and the price of the procedure will come down to rupees 6 7,000 rupees, because here you don't involve many people to do it. So that is why I am very fond of training people in use of such devices so they become independent and start using it. So in case any one of you who's there with me, who is part of our training team, any of our alumnus, my colleagues, my friends, they can write on the screen how comfortable it is. Till now, we would have trained more than I think 1,500 people in the use of such a device. Very
Yes.
simple. तुषार आप भी तो आपने भी यूज किया होगा शायद ये डिवाइस
Yes,
on
sir. Yes,
my.
sir. Right.
Was it very difficult? I just want to ask you. Was it very
No, no,
difficult?
it's a very convenient. In fact, your self dependency improves, sir. You don't have to wait for so many people to do your procedures.
Yeah, so it's a very simple device. Anyone who can make a good cup of tea, they can use this device. It's so simple. So technology is there to help us. But problem comes that when technology comes, हम लोग ना भाग जाते हैं. We'll hide behind something. हम छुप जाते हैं एंड वी हायर पीपल टू रन दैट टेक्नोलॉजी. तो वो नहीं करना है. टेक्नोलॉजी को ग्रैब करना है, टेक्नोलॉजी को सीखना है. दैट विल रिड्यूस द प्राइस. In case you buy a technology, then we get four people to run that technology, and we spend all our time in doing cesareans and hysterectomies, then it won't work out for us. So it's a very good technology, Usha. Please go ahead and start using it.
Sir, so with respect to cost and new technologies, uh, uh, what is your advice sir, on the DNA fragmentation set? Shall we send all patients with a low count for a DNA fragmentation test of
Super question.
sperm
Super question.
analysis?
Super question. Super question. So, as
Sir.
till around 3 4 years back, we never believed in this DNA fragmentation index. We were evolving till around 17 18. I started DFI somewhere in around 17 18 19. I started. We always wondered it's a very complicated and messy test because it's got around 8 steps. The
Sir.
test costs somewhere around, for a doer, like what Usha said, 5,000, but in 5,000 price likha. So the kit may be costing you rupees, say 2 3,000 rupees per person. complicated tests, and outcome was not very very sure. But we were scared of the technology. As a gynecologist, को ना अच्छा लगता है cesarean करना, babies को receive करना. We feel happy in doing a surgery. Then we are moving towards IUI or IVF that we love. But sitting with the pipettes and making few micro droplets or pipetting agarose gel or putting 40 microns of cement sample into a pin drop tube, you have been through this. We
Yeah.
add some reagents, colors, that scares us. So again, I think I'm very happy to say that with all your blessings, we have trained more than 1,500 people in DFI till now. Everyone comes and learns the technology in 25 minutes flat. 25 मिनट के अंदर they learn and they go back from us. So when to do, सबसे पहले हमें डर निकाल दिया लोगों के बीच में से कि ये टेस्ट बहुत आसान है, ये टेस्ट बहुत आसान है, और यू कैन डू इट, लर्न इट विद इन हाफ एन आवर और 45 मिनट्स फ्रॉम अस. दैट्स ऑल यू नीड टू डू इट योरसेल्फ एंड गो बैक एंड स्टार्ट डूइंग इट. तो कब करना है ये टेस्ट? सब इंडिकेटेड नहीं होता है. So when somebody is having varicocele, somebody has got something like diabetes or hypertension, somebody who's a chronic smoker or somebody who's on drugs, somebody who's got any chronic medical illness, somebody who has got recurrent IUI failure, implantation failure. So these sort of things, when there are failures, elderly people, anyone more than 38 years of age. So अगर हम पूरा का पूरा एक सिनेरियो देखें, it's become a very common indication. It's become a very common indication. Of course, the sperm count is okay. You don't need to do. In case age is more than 38, you should do it in all, I feel. And as the person is having a unexplained infertility or failures, she's not conceiving after 3 to 4 years of marriage, or sperm count is low, there is OAT. When these sort of things come, I think it's indicated. So I'll say that out of 10 people, in my setting, it is indicated in around 6 people or 7 people out of 10, because I get referrals. Maybe 8 people is recommended. But remember that again, it's a technology. I've seen people charging quite a lot for this technology. They make it very expensive. They charge 8,000, 9,000 for the technology. That should be avoided. I think in case you learn it yourself, I always say that Atmanirbhar Bharat. We have to the mission developed India, no? That's what our आदरणीय प्रधानमंत्री जी कहते हैं कि आत्मनिर्भर भारत होना चाहिए. So हमको भी आत्मनिर्भर बनना है इसके अंदर. हमें खुद करना है ये काम. हम करते क्या है, एक अच्छा टेक्नोलॉजी आया एंड देन वी स्टार्ट, we don't understand, we want to adapt, and then we hire people to run that technology, and then the price starts getting add-ons. So the test which costs you rupees 2,000 will become 10,000. That's what I say, that learn the technology. It's a very good test. I feel in my setup, 8 out of 10 people need it. Maybe in your setting, 4 out of 10 people need it. But it is needed. It's needed, and it can make a difference, because अगर DFI high है, in that case we can go in for Pixie or we can go in for microfluidics. So they are all coming together. It's something like, it's a meshwork of neurons. Something goes wrong, we have to move to the next technology. पर हम तभी कर पाएंगे जब हम खुद काम करना शुरू करेंगे. We can't depend upon other people. It won't happen. Yeah, lovely. Very good question.
Sir, sir, I think the any role of DNA fragment decrease motility. The test itself indicates, so the motility is there. The sperm count is sperm quality is a compromise. So we should ideally go for the DNA fragmentation test to choose the ideal sperm to be used for the process of in vitro fertilization, where we need a very minimum one or two sperms.
पता है क्या तुषार, the concept is that we are aware that एक अच्छा sperm क्या होता है, which can
Sir,
move, we can fertilize.
yeah,
And what is the quality in the sperm which will make it fertilize? Good DNA. जिस sperm का DNA tightly packed है, वो sperm मजबूत है.
must
Like
be.
anyone who's got good biceps.
Yeah,
Biceps. He's a strong man. Sperm has to have a tightly packed DNA. Simple question and simple answer.
sir,
When tightly packed DNA रहेगा ना, तो sperm का जो density है ना DNA का, that is very high. The density should be 1.019 approximately. Density is high, that's a healthy sperm. And the
sir,
sperm, when they have DNA fragmentation, the sperm will have damage to their DNA. And then definitely, yes, when they have a damage, sperm's motility will definitely reduce. because they become bigger. The head may become bigger. The head may become broken. So it doesn't work that way. So I think DNA fragmentation is a very good test to be done, but it's not surety that in case that DNA damage is there, sperm will be immotile. ऐसा नहीं है. Maybe it will be slowly progressive. Maybe it will be rapidly progressive. So that's the reason that whenever we have OAT, we should carry out DNA fragmentation to assess it. And then if we get DNA fragmentation index more than 20, then we should
That,
treat the patient. Treat the patient. See, we do so much for the female partner. For female partner, we have so many things to be done, but for the male partner, we do nothing. So I always say, hold
yes.
on, रुक जाओ, रिपोर्ट को चेक करो, रिपोर्ट को पढ़ो और वेट करो. लेट द मेल हील. कम से कम 3-4 महीने उसको मौका दो उसका स्पर्म काउंट ठीक करने का, देन वी कैन मूव इट. डोंट बी इन हरी.
सर, सर अभी बात आई गई है तो आई वुड लाइक टू emphasize on analysis method also. Like with an traditionally we suppose lab is somewhere in the rural areas, or or a place like a district place where a good analysis system is not available with the pathologist or any RT center. It's a better to have automated analyzers which are now come up in the market, sir. They give you at least a better picturization. What is your message on this, sir?
See, we train people a lot on these modern devices. We got nearly everything available with us. We're training all of you on different devices. We are training ourselves every day. I say that these devices are very good. But जब तक आप अपने हाथ के साथ काम नहीं करेंगे, so anyone who wants to learn analysis for initial 3 to 4 months, 6 months, 1 year, few years, they should do it with their own hand.
Yes.
Understand the staining patterns, understand the motility, use a sperm counting chamber, and come to an answer by yourself. Later on, yes, you can shift to a device which costs around rupees 2 lakh rupees, about 1.5 to 30 lakh rupees. You can pick up your modality. But in the beginning, I think you should do things with your own hand. I love
Uh,
working with your own hands, number one. Number two,
right.
people who have no work. इनके पास काम कम है ना. lot of people who are having a very busy ops practice.
Yes, sir.
उनके पास इतना काम नहीं है इनफर्टिलिटी का, पर वो करना चाहते हैं. So they can't afford a technician or a good technician. Or the people who are overworked. बहुत काम है, खूब सैंपल आते हैं रोज, उनको ये मशीन खरीदनी चाहिए. But for the people who are doing average amount of work, say 1 or 2 samples every day, they should be doing it themselves, I feel so.
Themselves.
And in case your work becomes very heavy, you can buy a machine. But machines are super. I mean, we train people on machines from multiple companies. My favorite is MES. You will see that machine at our place. It's a huge machine. Because smaller machines also, they work very well. The reporting is very good. And it's always good to take the help of the machine, which can also help you in bit of combining AI with the findings you're getting. But I say that to as for a beginner, अपने हाथ के साथ काम करो. कहीं ऐसा मत हो that you buy technology and then you have to
And
hire
you,
technology to run that technology, and
yes,
technology is giving interpretation. Then the human touch goes. You have to have that human touch. This is very very important. तो हाथ के साथ काम करना चाहिए. बट अगर आप खरीदना चाहें तो इट्स a very good machine. But they should be FDA approved. That's important. See whether it's got an FDA approved, and they work according to WHO manual
analysis
6
criteria 2023.
edition. This is important for us.
Sir. Sir, next, as we are talking about these things, what is the role of supplements? Nowadays, a variety of supplements available in market for a fertility patient, infertility patient. Let it be male factor, let it be female factor. You think, sir, it really affects the outcome in either way?
I myself write a large amount of supplementations. I do write. But I
Sir,
write for the people because my OPD starts at 40 years of age. My patients are somewhere around 38 to 43, 44. I don't get young clientele.
yes.
And by 38, 39, 40, and these
Result
people
has
are all
almost,
busy people, very busy people. They don't look after themselves. They're on that uphill, they're working hard. I do give supplementation in terms of I give calcium, I give vitamin E, I give them multivitamin tablets, I give them supplements for their semen factor in case they're more than 38 years of age, or in case it is indicated for their semen factor. For the females, we do give supplementations for PCOD patients. We do give them supplementation for poor ovarian reserve or a diminished ovarian response. So we give supplementation, but I think these supplementations should not become a fashion. The problem is that people are giving supplementations as they give it before patient comes. They start adding supplementations. So that should not be done like that. I believe in a lot of naturopathy. I feel that they should have. First of all, they should be happy. In case the people are happy, the DNA fragmentation will become fine. The first thing when they ask, my DFI कल ही एक example देता हूँ मैं आपको. One very educated couple, they came to me. They tell me that his DFI was 54%, very high. He said, "What is the cause of my DFI? I've been to so many clinics, but you told me my DFI is high. I've got a high-end machine which calculates DFI now." So I said, "It is stress. That's all. I mean, you're a non-smoker, non-drinker. You're a typical family man coming home at 7 o'clock, working from home. Nothing else you need. You need good amount of sleep. Time पे नींद पूरी करो. Do some walking. Walk 10,000 steps a day, and you'll be good." Then they told me that they are in a total mess here. Initially, they all want to say that we are all fine, no? We're very happy. We are very happy everywhere. But when you probe, then they break down, and they're in a mess completely. So I think most important is mental balance. Control your mind, and your semen factor will come under control half the time. For all others, there can be some supplementations. Same with the female partner. Here, I don't know. It's not about the stress only. There can be many reasons that they start having low AMH. The AMH is low or antral follicular count is low. We need to treat them. But to treat them again, we should not go like just ordering for multiple medications. I personally feel that I give them large amount of things like I give them kacha amla. See what I do? I believe in what is relevant. I give them
Vitamin C
kacha
and antioxidant.
amla. Gooseberry is a powerhouse, a power bank of antioxidants. Give them kacha
Yes.
amla. They're very happy in that. I give them raisins. I give them walnuts. I give them chocolates. I give a lot of dark chocolates to the people who have got low sperm count. It's worked pretty well for the people. I give goji berries for the people. I believe a lot in the naturopathy, and it's working well for me. Yes, of course, we have medications for the men. We give them something like betaine, we give them CoQs, we give them carnitines, but they should have some indications. We shouldn't be offering, like anyone who comes to is pregnant now, Tushar, any lady comes pregnant, we give them folic acid and calcium. So any
Yes.
male coming to us, we give them carnitines and CoQs. तो वो सब नहीं करना चाहिए. They should be able to, if not indicated, don't give. And 50% of people is not indicated.
We should be
For all
selective
others,
rather than empirical, sir. That is what his message is.
yeah, yeah, it's empirical. Be very careful. They can harm. See, I ask people, what are you giving? They say, हमें नहीं पता. हमने कहीं पढ़ा था, हमने लिखना शुरू कर दिया. Sometimes they can cause damage. Some of them are we are always have to combine hydrophilic and hydrophobic. Because if we keep
Yes.
giving large number of drugs in wrong combinations, they can be harmful. And for the female partner, somebody wrote what how long you give pre-medication to PCO patients. So for PCO patients, there is no pre-medication actually needed. It's not needed. We have some recommendations about giving them CoQs. Yes, we give CoQs. I give them multivitamins. I personally give. Then there are
Amino
something like
sequence.
DCI and MCI combinations. Again, debatable. Uh, I don't know whether I should be speaking here or not, but a lot of Italian groups working on DCI MCI combinations. A lot of people are working on this, but I don't think it's. Uh, we need more evidence. We need more evidence.
Evidence.
Some people give metformin. I do give metformin to people in case they have any glycemic imbalance. I do give DCI MCI to the people who can't tolerate metformin. But there has to be some indication. High BMI, altered blood sugar values I do give, but not as a routine. So, in case I have to give one drug, I normally give some sort of antioxidants like CoQs and multivitamins and vitamin D3, which I feel is deficient in the people who've got PCOS. The thing is that we give them so many medications, but we don't do the thyroid. They have hypothyroidism. So
Yeah.
we have to look at what they're having and then treat. हमारे हाथ में बंदूक है. तो चलानी नहीं है. We have to see where we have to fire. And in case we are having a patient with a poor ovarian reserve, yes, we do give them something like we give them melatonin, we give DHEAs, we give transdermal androgens. We do give, but it has to be regulated. Not give we make them a whole potly of drugs and give it to them. That should not be done. And they don't have much evidence. Also, I like to
No.
add that they don't have much great evidence that they do magic. The evidence is that they give us happiness that we are doing something, but how much they are getting benefited, nobody knows.
In
They're
fact,
empirical drugs.
it can be only supplements, sir. It won't work also without modifying your lifestyles, like a quitting of smoking or reducing of weight. That is more important, which gives a better result than providing a supplements.
Exactly. I
So,
think losing weight, walking 10,000 steps a day, being happy, and sleeping for 8 hours a day is what a lot of people
it's
they
required
need.
for
But
normal style, normal routine.
या पर जो चीज़ मिलती है ना आसानी के साथ में वो हम नहीं करना चाहते ना.
But
See, we have got very good foods in our refrigerators. We got those lovely, we get carrots, we got radish, we got spinach. So many things we can eat. But what we do is that we have to order a pizza. I love my pizza any day over any nice salad, green salad. I like to love to have a pizza. I love to have some nice garlic bread. घर में अच्छा खाना नहीं खाते हम लोग. As a result, that is causing the problem. So, how long do you give metformin while give you stimulation? Metformin is not indicated for the patient. First of all, Dr. Matu, it is not it's not indicated. But in case there are some studies saying that it can reduce the chance of ovarian hyperstimulation. You may give, but after the pregnancy comes positive, if we start metformin around 15-20 days prior and carry on in the whole cycle, and after the pregnancy test comes positive, then we stop metformin. I stop metformin. I don't give it routinely. It's only to reduce the prognosis, improve the prognosis of ovarian hyperstimulation, not for routine for the people. Until they have an altered glycemic profile, they have got fasting blood sugar is high or something is there. Till that time, we don't give them routinely. Not indicated. You can refer to the ASHRAE guidelines. They have said very clearly. And insulin sensitizers, again, uh, I really can't tell you because it is not recommended. It is not recommended at all. So I can't say till what time should you be giving. Since it's not recommended, we do give. I also do give sometimes when the people are having altered blood sugar. That time also we normally continue till their test comes positive, then we stop it. Yes, next.
sir, my next question is in a very recurrent failure patients for IVF cycle, how much rest we should offer to the patient before in between two cycles? For example, this cycle goes when we couldn't pick up, then what is ideal time we should tell the lady ki rest for a while and then we'll start again? I think will it help her for a better outcome?
Yes. First of all, whenever you have a failure, in my case, when they come for the second cycle, मुझे आके बोलेंगे सर अभी क्या करेंगे मेरे लिए आप कुछ नया क्या करने वाले हैं कोई नई दवाइयाँ कुछ नई टैबलेट्स आई सेड नथिंग देन व्हाई शुड फॉलो अप विद यू हम आपके पास क्यों आए आप तो वही पहले किया और आप फेल हो गए वही
वही
चीज
था.
दोबारा करोगे दोबारा फेल हो गए द सेम थिंग सेम वे repeatedly you have the same results, we have heard about that. But I believe in a different thing. I say I'm not making a car. I'm not Henry Ford who forgot to put in reverse gear in his car. I'm not. We're not that level intellectuals. That time eras were different, but now things are very well defined. See, in case I do a case, I've already protocol wise, I'm sure what I'm doing, and same thing I'll be repeating. Because I have to change it. In that case, I should change it before only. Then why should I say, okay, I'll try this, then I will change it? That's one way of looking at it. But whenever I fail in my protocols and I don't get good outcome in terms of pregnancy or embryos, I take a break of minimum 2 months. I'm never
Too
in a
much.
hurry. I don't believe in doing cycles back to back. I don't believe in doing random protocols until it's a cancer patient. I don't believe in duostims until it's a cancer patient. I like to give them a break, give them some supplementations. The protocol will remain the same, what I have done before, but I like to give them some supplementations. Second time, probably I'll give them something more empirical. I may add growth hormone. I may add growth hormone.
Those are
I may like to do an yeah. I may like to do an hysteroscopy for them. Though I never do any uh, surgeries of this nature. But in case I think it's fine, they are failing. I may like to repeat a 3D scan for them again, or I may do give them growth hormone, give them some more antioxidants, analyze them. But I think 2 months gap or 3 months gap is minimum I request them to take so that by that time they are settled down and many times they become pregnant by themselves only.
yes, sir.
In large number of cases when they become relaxed, no, कि fail हो गया IVF भी कराया IVF भी fail हो गया, they go on a छुट्टी and they come back pregnant.
With
So I think we should treat our people with a lot of dignity and respect. There is no hurry here. होता है कि वी आर स्केर्ड दैट वी मे लूज ए पेशेंट, लगता है कि चला जाएगा वापस नहीं आएगा. ऐसा नहीं होता है. इन केस यू आर ट्रुथफुल, you will have truthful patients coming to you also. That's the way I look at it. So no hurry. Take a break of around 2-3 months, then you start again. Yes.
Absolutely rightly said, sir. Sir, so my next, I would like to ask you, sir, one thing. With respect to IVF, when we counsel the patient, so we more than it's like when we counsel the patient, how much we should tell the patient or a couple about the as we talk about success rate, as we talk about the new procedures, what the time they should spend in the thorough process. They should be mentally prepared. This is basically question for our patients, sir, who are live on the site at present, not for doctors.
Yes.
What is the invest? It's not only investment of money; it's an investment of time. That's why I'm asking. I'm putting this question, sir.
But the money people have, money comes from bank, they'll come from their bank to our bank to somewhere else. Money keeps flowing. Important here is what comes from your heart, and what comes from your heart and what comes from above. It is our conscious. So heart and conscious have to come together. First of all, remember that it is one surgery which is done. Pickup is done within 15 minutes, and embryo transfer in 1 minute. So total OT time is barely 15-20 minutes for a patient for OPU, and around 3-4 minutes without any anesthesia for an embryo transfer. Lab work can't be more than half an hour. Whatever you do, lab work is never more than half an hour or 40 minutes, including everything. We
Yeah.
bill our patients around 2 lakh rupees for this. On average, we bill them 2 lakh rupees. I feel that we should be very, very gentle and kind to them, and they need to know. वो जानना चाह रहे हैं वो जानना चाह रहे हैं कि what is happening to us, what is happening to our body. So all the ultrasounds, starting with all the ultrasounds and with all the outcome details, we should talk to the whole family. Here, please don't talk to the husband only. Always talk to the husband's parents or the girl's parents. They should be part of the ultrasound. I always call them for ultrasound also. They themselves assess their follicles, they themselves see how the ovaries are placed, and then they themselves give you the outcome. When they're seeing 10x, they get 10x, they're very happy in that. Because ovary is not approachable, they know that they may not get good number of x, ovary may not be approachable. So they are part of that treatment. You make the patient part of the treatment because in case you won't teach, they will go to internet and start reading. And you can know that by internet, by Dr. Google, they will learn many things which they don't understand, and then they start going wrong. So this
Sir.
is the very, very important part, that we should tell them what is right, what is wrong, and do proper counseling for them, and do counseling by writing. I normally, when I do counseling, I tell them, you record me. I say, take out a mobile phone and record me. So when they record me, they have some sort of ready-made reckoner for them. So, and for this is very, very important that in IVF we should give minimum 1 hour. We should give them 1 hour sessions. The counseling is done by the nurse half the time or by a counselor who are not trained in this. So patient is our responsibility. So I normally don't see more than 8 patients a day. and every patient takes 1 hour, minimum 1 hour they take. Have minimal visits. Don't call them repeatedly. Come after 4 days, 5 days. That's not the way. I think we should do their IVF in around 3 to 4 visits, not more than that, or 5 visits. And every visit should take between 45 minutes to 1 hour. This is very very important.
So we
Give them
must say,
time.
sir, sir. So we
Yeah.
must say, sir, counseling skill is also one of the technique for a better outcome. The patients are relaxed, a family is supportive, and doctor is less apprehensive that what I have to tell them again after failure. So the
Yeah. So
question
once
is,
you, yeah. So once you talk to them, we always have very good outcome. We have to talk to them. It's very very important. So बात करना बहुत
yes,
जरूरी है. बहुत जरूरी है बात करना. And talking them truthfully. See, telling them that my rate is 80% or
yeah,
70% is not correct when her age is 41, husband is 43, and you are selling yourself by saying we are not selling ourselves, but we are. They get misguided many times when they see blinking everywhere. The OPDs have put those charts, beautiful charts saying that our result is 85%, 70%. They feel that हमारा भी 70% chance है,
huh,
but उनका AMH is 0.2, 0.3. Uh, so you have to understand that. And PCO patient, you feel very happy that we'll get very good outcome in them. That's not also the right answer.
no,
Many times PCOs, they give you very less number of X. Sometimes they don't get stimulated. And not telling a PC, telling that I'm gonna charge you rupees 2 lakhs for a patient or 1.5 for a patient. When you got an AMH of got an AMH of 6.5 or 7 or 8, what do you do? The pressing may go to 3 lakhs because you're putting them on a chronic low dose protocol. It continues for a long time. You get my point? The
yes,
dose,
sir,
the drug dosage from 2500 or 2700 may go to 3300. The rates may go high.
right,
So we have to be very, very careful when we counsel the people because they need help here. We have to be with them. Yes.
yeah. So there is a question: how to prepare endometrium after 2 times of post septal resection? And one more thing: do you after septal resection you advise to put the Foley's for 24 hours?
Yeah, so up 2 times septal resection, Asherman syndrome. So yeah, 2 time. See, we have to see that why are we doing 2 times septal resection, and
Resection.
this we have to see how we bring good endometrium. Asherman syndrome actually has got bridging lesions. Here we have got bridge lesions which come between two. We got two unhealthy
Village.
decidua. We got bacillus layers coming together and falling. They call bridges, or we have skip lesions. So between the skip lesions, the endometrium is okay. So I think this is from Dr. Baluswamy. So in case we do a 3D scan and we find that there's a triple layer endometrium coming between two bridge or skip lesions, we can remove that skip lesions and do gentle curettage, and then probably it will come back again. It will start growing. If you do some PRP, it may start growing. But remember that in case the whole of endometrium is gone bad, it can be something like a chronic endometritis, or the big patches of endometrium has got stuck together. In that case, you got we don't get any triple layer endometrium when we do a 3D scan. It may not
Right.
help us. So I am skeptical that why do we do 2 time septal resection? In case we do septal resection here, I think we should you can put a Foley's, nothing wrong in it. You can put some IUD, absolutely okay. And Foley's you don't put for a very long time, maximum 24 to 48 hours. Many studies say that don't even put Foley's catheter. They say don't put
Yeah.
Foley's catheter. It's not necessary to put Foley's catheter. What do you do in your practice, Tushar?
Sir, it's
What do
better
you
to
do?
put IUD. Intrauterine device would better help,
I
or
think
you can add a with Primarine for getting up a good endometrium for some time.
this is what I'm
Or
saying.
just
This
a
is what I'm
estrogen spray nowadays are available.
Yeah, this is what I'm coming to. That putting Foley's is always not the only option here. You can put an IUD. Because you put Foley's put for a short duration. But we can't put Foley's for a long duration. That may lead to infection. And you can put them on estrogens. You can put an IUD. That's a way we handle. But second time mat karna kabhi. Second time separate section. I am not very sure is going to give you good outcome or not. But such cases they do benefit with PRP in case there is uh, the skip lesions are less and we have healthy endometrium. We can do
In
it.
between adhesions.
Yeah, yeah, correct. So Goyal, Shish Goyal says that PPOs, so progesterone primed cycles or intact protocol for PCO patients. अभी क्या हो रहा है, Dr. Goyal, we are basically focused on, we do PPOS, PPOS for donor cycles till now. Though it is changing, our ways of thinking are changing. But till now, we are trying to focus on PPOS only for donor cycles, because in the donor cycles we don't have to do any embryo transfer. So we do PPOS. When we do PPOS, we cannot do fresh embryo transfer, and we are now reverting back to Dr. Shrest.
to
We are reverting back to fresh embryo transfer nowadays quite a lot, because doing a fresh embryo transfer gives you equally good outcome. So anyone who's a poor responder, it's always good to do fresh embryo transfer. So fresh embryo transfer is better. There we can't do any PPOS. But your question is about PCO patients. So I know what you're saying. I exactly know you're talking about PCOs. I'm coming to, and you've written frozen cycle. I was coming to this part now. My initial was poor responder, because you have put me a question which I thought I'll cover for everyone here. So for a PCOS patient, finally, I think very soon, I feel, if you ask me, we'll be shifting completely to PCOS.
fresh cycle.
PCOS is a very good method. We can do only in PCOS, because as such we do for the number transfer cycle. हमने करना ही FET है, so why not PCOS? We should be doing it, and already people are doing it. But if you look at the whole world, people are still scared about how to do it. I think very soon we'll be shifting to anyone who needs frozen cycle. PPOS is a cheaper option, is a better option, and with minimal chance of their going into ovarian hyperstimulation. So I'm totally with you. I agree with you. I echo your thoughts. I My mind resonates with whatever you have done. Uh, PPOS is a very good method to handle any case in which we want to do frozen embryo transfer. I'm with you. Yes.
I think there are no more questions from the viewers side, sir. Sir, I would like you to suggest one more thing, sir. Ideal time for ET, sir.
Yeah.
Uh, More than ideal condition, I would like to focus on ideal time for ET, sir.
आइडियल
Over
टाइम
better.
का तो मुझे नहीं पता. वी डोंट फॉलो दैट टाइप ऑफ पैटर्न टिल येट कि आइडियल टाइम क्या है. बट आई थिंक सो आइडियल डे बता सकता हूँ मैं आपको. आइडियल पार्ट ऑफ द डे इज
Sir,
वेरी.
sir,
So ideal time for the window of implantation, we had an era coming. Finally, it is gone. Not many people are following era anymore. So what we need to do is we need to day three embryo we transfer on day four early morning, and day five embryo we transfer on day six early morning. So we give complete 5 days of resistance support for blast, which is frozen on
sir.
day five, and day three full support we give for day three embryos, and or day four embryos, 4 full days, and fifth day early morning we transfer. This is what we normally do.
Okay, sir.
But time factor, I don't believe much. I don't have much of experience. We stopped doing ERA after using it for around 10, 15, 20 patients, because there are many papers saying that ERA is not very, until it's really indicated, we don't carry out any ERAs.
Sir. One more question has come, sir. Platelet-rich plasma in a poor ovarian reserve case. Its a role and methods for PRP
Again,
injection,
it's very
TBS or
relevant.
laparoscopy.
For a thin endometrium, I say we can do PRP. I agree to that. But I don't agree to using PRP in an ovarian reserve case, because we don't have recommendations over that. You want to use, you can use. There's nothing wrong in it. You can prepare the PRP as a routine, and I normally put it by TVS route, not by the laparoscopic route. So TVS route is, I feel more comfortable doing a TVS and just putting the PRP there. I don't use laparoscopic route. But I'll say that for poor ovarian reserve, some people claim, but we still need to get more evidence. We need to get more studies over that. This point of time, I won't recommend doing PRP for poor ovarian reserve. This is what my take-home message will be. But अगर करना है तो I prefer doing. I've done large number of cases when it came in the country, but I prefer TBS as compared to the laparoscopic method. We use an OPU needle and inject. Okay.
Sir, last question, as most of the doctors are only asking the queries. Does the batch cycles affect the outcome, sir? What do you think? What
Now,
is your
batch IVF can be very, very good. Very, very good, done by somebody who's Dr. Usha, you're right. You read in the journal. I fully agree with you. There are a few case reports are there, and we have also done it after following the case reports. But there are more case reports saying don't do it. So nobody says don't do it. It is not recommended. And I always say that when the technology comes, you must start working on that, because until you won't try, how will you know it's not working on the patients? So I am very much proactive in picking up the new technologies, but enough evidence says that we should not be doing PRP as a routine in a poor ovarian responder. It needs more evidence. Number one, batch IVF is I did batch IVF in the army for more than 15 years. We did batches of 30 cases, 40 cases, but that was wrong. Issue was that that time uh, different working conditions. We did batch IVF in large numbers. So batch IVF being done for a batch of 8 to 10 people is very good, because we got now we had box incubators, but nowadays we have got a benchtop incubators. That's number one. Number two, these incubators have got one chamber per patient, so we don't disturb any other patient. We save media, we save disposables, and
yeah,
I think it's a very good way to do a batch IVF. I mean, batch IVF के साथ you can, in case you're doing FET, frozen embryo transfer, no problem, nothing like it. You make large number of blasts, freeze them, and then you can be relaxed for some time, and you can spend some time with yourself, with your own life. So batch IVF is not bad, but to be done by the right people. So अभी आप batch IVF कर रहे हैं, suddenly your XC machine breaks down. You don't want to do batch IVF and your incubator breaks down. You're doing batch IVF and your the something goes wrong with one bottle of media which you have, it spills. Then what do you do?
yeah,
Uh, Power goes off. What do you do? Your embryologist doesn't turn up. What do you do? So in case you are working appropriately, like in the army, we had big experience with batch IVF for more than 13, 14 years. There also we face these problems once in a while, but overall it's good in a setup where you have enough people, doctors working with you. So that's good. But routinely, batch IVF should not be done by somebody sitting in a periphery. Sitting in a periphery, don't do batch IVF, because you should have good backup of everything coming to you.
yeah,
Don't do a batch IVF because it looks stylish. It was the methodology to work. But nowadays, have double incubators, have double manifolds working properly, have engineer of the company coming and sitting with you in case the machine breaks down. It should happen that something goes wrong and you don't know. That shouldn't happen. But batch IVF is not bad. That's what I want to tell you. It's a good way.
there is a question by Dr. Shrestha Goyal, sir. Ki, what are the indication other than Asherman for a subendometrial stem cell therapy? So, is it in a practice?
Yeah, there are a few papers which came. One came from India only by Dr. Sunita. She's a very dear friend of ours, and she does a lot of stem cell therapies. She reported a pregnancy also. But understand that these are all things which we are experimental. And I don't want patients to take stress of paying so much of money. This is what I feel, but nothing wrong in it. I feel that in case you guide them properly, you take your ethical clearance, take an ethical clearance, and then you can do PRP methods. Uh, you can do whatever you want to do. But stem cell therapies will work. I don't say they don't work, but I think if we need more experience, they are experimental and they are expensive. So just don't do a thing because it is fashionable. That's the advice I want to give to you. In case the endometrium has got a chronic endometritis and whole of the endometrium is patchy and gluey and sticky, then this thing won't help you. PRP won't, putting stem cell therapy may not help you, but it'll add on to the expenditure. So be very careful for as you do your patient selection.
Sir, if there is a cyst on day two, shall we start on a follicular stimulation, or if
कितने
not,
बड़ा
what
cyst है?
is
कितना बड़ा cyst है? Depends upon the size of the cyst.
size
In
of
case
cyst?
cyst, I don't know. He has written follicle or cyst. So on day two, it will be a follicle only, or maybe. So follicles are between 2 to 9 millimeters. So as we have always taught, we have read, we have learned that follicles should be between 2 to 9 millimeter, and they should be synchronous follicle. All should be same similar follicle should be there. So in case you get a cyst, which is now I don't know what is the meaning of cyst here. What type of cyst are we talking about here? Uh, in case we got an asynchronous follicles, one is around say 1.2 centimeter, others are 8, 9, 8 millimeter. I think it's a call you'll have to take. But normally for a synchronous growth, I always feel, say 11, if you written 11 millimeter is the answer I have got from Dr. Matu's clinic. 11 millimeter, you may start, nothing wrong in it, but there should be a follicle. But I have to see that what is the size of other follicles. In case I find that there are 10 follicles, all are 11 millimeter, I won't do. I won't do. Number one. In case one follicle is 11 millimeter, other are 7 to 8 millimeter, we can do. But be prepared that your 11 millimeter follicle will grow fast. That will grow faster, and probably finally you may have to sacrifice it. Because in case other are 7 to 8 millimeter, this is 11 millimeter, when others will be 14 millimeter or 15 millimeter, this may become 18 millimeter. So this will grow very fast. So then you should know how to sacrifice that follicle and then take other small follicles to grow. But ideally, in case is high risk in terms of age, parity, or previous failures, try to get a uniform crop. Try to get the follicles which are all between 2 to 8 millimeter. They give you better outcome. They need not worry, because it's not only doing a case, it's getting a cohort, proper equal cohort, and this is very important for us to look at when we are doing a difficult case. Yes. So there's a debate about IUD, Foley that will always carry on. So Shweta, this is always carry on. We all work with our own experience. Some people gave estrogen, some people gave copper T, some people gave Foleys. So Foleys is always good. We are not saying Foleys is bad, but don't give Foleys for a long time, because then Foleys can lead to infections also. That's what we always said. So Foleys is not bad. We agree with you. Okay, so this is the initial talk. This is a part of our Facebook Live that would be on Facebook and finally go to our YouTube channel. You can visit our YouTube channel and watch it there. And absolutely okay, great. Anything else,
So, so,
Tushar?
so no more questions from my side. I couldn't find any more questions from audience also. So,
Great.
with your permission, we may
Yeah,
conclude today's session.
we can conclude, and thank you so much everyone for joining. And
Sir, thanks a lot for enlightening and with the new knowledge, with the new techniques and the freshen up the previous knowledge also, sir. So I'm very
thanks.
grateful on behalf of all the audience. Myself is very grateful to you, sir. Thanks a lot.
So do the right thing, Tushar. Everyone when goes back from here, do the right thing. Right is always right, wrong is always wrong.
Always
Do the
wrong,
right thing. When
sir.
technology is there, it doesn't mean that we should use every technology. It doesn't mean that we should use every drug. We should be very, very selective. That's important. Remember that in case even patients can afford, it is not right to make their bills go sky high. That's not the right thing to do.
That's
So
not ethical.
what for me, what an amla can do and a dark chocolate can do, which is very rich in coca, or what a walnut or some honey can do for the patient. Why should I give them expensive medications which are costing them rupees 200 every day?
Yes, sir.
So this call you will have to take. For that, we have to understand what we are dealing with. Patients are, remember that one day even we'll be a patient. Then we'll always say why are doctors writing so many medications and why they're overwhelming us. So always think that one day you will be across the board, and then how you feel in case you are overwhelmed. And we shouldn't experiment with the patient. कोई ज़रूरी नहीं है कि हम हर स्टडी करने बैठ जाएं. ये दवाइयाँ आई हैं हर पेशेंट पे, वो हम ट्राई करना शुरू करें. आई थिंक देयर आर सम ड्रग्स व्हिच आर रिकमेंडेड, यूज देम ओनली टू बिगिन विद. And don't come under pressure from any new brand or any new drug. Do what is right for the patient and for yourself in the long run. So thank you so much, everyone. It was
Thank you,
wonderful
sir.
being with
Thank
you.
you.
And we connect again after 15 days with a new topic. So we really enjoyed being with all of you. And Tushar, thank you so much for being with me. You're always a big support for me, and I wish you all the best in your life.
Thank you very much, sir. All yours, sir. So,
Thank you so much, everyone. Have a nice day and have a wonderful Diwali. Thank you. Bye. Take care.
thank you
Bye.
all. Thank you all once again. Wish you a happy Diwali ahead. Thanks a lot.
Thank you.